Good evening, everyone. My name is Mustafa Karim Al-Shahni from Iraqi Stroke Network team. Today, we will start our sixth educational webinar with super expert speaker talking about a very important topic. Now, I leave the word to our panelist, Dr. Professor Hayder Hasson, a professor of neurology and a teacher of many neurologists in Iraq, including me. So please, Professor Hayder, go on.
Thank you very much, Dr. Mustafa, and ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. Jum'ah Mubarak for all, and I hope all are fine. In fact, on behalf of the Stroke Society Network in Iraq, we welcome all by our expert speaking, Dr. Marwa from UAE, and I would like to shed the light on the important issues about this topic. In fact, you know, cerebral venous thrombosis is uncommon in comparison to the arterial stroke, and an incidence not more than 2 per 100,000 population every year. And the incidence really is increasing, not only affecting female, young. You know, there is a female preponderance in this issue. There is increasing in the number, especially we observe that obviously in the pandemic of COVID-19, and with many issues, we come across maybe daily cases of cerebral venous thrombosis in COVID-19 and our experience, and have been enriched because of that, because, you know, this is one of the common neurological complications we come across in that time. Not only this issue, but also to a relation into vaccine, immune-mediated thrombotic thrombocytopenic problem with the some of the vaccines, like adenovirus vaccines. Anyhow, the various manifestation of this disease is quite variable, make the diagnosis sometime in very subtle. The patient might present with very minimal symptoms that passed unnoticed to the severe devastating events that need, in fact, immediate surgical approach like craniotomy, just as a life-saving measure. Anyhow, there is big things about the use of direct or anticoagulation, which is not inferior to the potassium antagonist anticoagulation, even the use of DAWAC in the pediatric age group with the cerebral venous thrombosis. There's many issues regarding the endovascular therapeutic approach. Yes, still now is not very well validated data we have, but it's interesting issue to be clarified in near future. I will leave the floor to our distinguished speaker, Dr. Maria from UAE, to enrich our knowledge about this interesting issue. Please, Dr. Maria.
I just want to invite Dr. Sara to encourage participants. She will lead the Q&A section. And there should be an introduction for Dr. Maria. Good evening.
Good evening, everyone. I am Dr. Sara, neurologist. Today I will be read the question in this end of this lecture. I hope everyone want to write down comment or question. Feel free to write that I will discuss, inshallah, at the end of this lecture, inshallah. Thank you.
Thank you very much. So today we have extraordinary speaker. So Dr. Maria Khan Junaidi. She is a vascular neurologist currently working in Rashid Hospital in Dubai, UAE. She graduated from Aga Khan University in Karachi, Pakistan, and she had a joint vascular fellowship program, and she has also fellowship in translational research and had a master degree in epidemiology and biostatistics. And she is now working in 2 areas in Middle East. So she is teaching faculty since 2020 for virtual stroke fellowship organized by All Pakistan Physicians of North America, APPNA Academy. Proud I'm one of her students now. And the MINASO, the Middle East and North African Stroke Organization. And she has research interests in geographical, ethnic, and sex differences in stroke epidemiology and access to healthcare, and she has over 50 publications in the international peer-reviewed journals. She is also the national coordinator of the CITES registry from UAE and is involved in the several CITES-based research projects in the region. She has recently been elected as a board member to represent the Middle East, Africa, and Eastern Mediterranean region in the World Stroke Organization. So the word is yours, Madam.
Thank you very much, Dr. Mustafa, and I'm very happy to be here with your stroke network from Iraq. And as part of the MENA Stroke Organization, it is our very great pleasure to liaise with your stroke society. And we'd be very happy for any future collaborations with your stroke organization as well. Because we are one region, and I think we should support each other as we grow in our stroke networks throughout the region. So any future collaborations would be very much welcome, and we'd be happy for any future opportunities also to work together, inshallah. And thank you for this invitation, and thank you for your kind introduction. The topic that you requested today is something that is also very close to my heart. I've spoken previously quite a lot on cerebral venous thrombosis, and I have some research also on this topic. Cerebral venous thrombosis is, as was mentioned by the professor earlier, he's given a very nice review of what I will be talking about in this 30 to 40 minute talk. Basically, I don't have any disclosures that are pertinent to this talk. And this is a basic outline of what I will be covering. And he's very nicely summarized, the main topic that will be covered here. So I will talk briefly about the epidemiology of cerebral venous thrombosis with some reference to the disease prevalence in our part, whatever data is available. Then we will talk about the determinants or the risk factors that are leading to cerebral venous thrombosis. What are the common presentations? And I'm sure that cerebral venous thrombosis is not an uncommon presentation for a lot of us. We see it quite frequently in our practice. And then we'll touch a little bit upon the management aspects, the medical, the interventional management, the role of surgery in some cases, and then, of course, the prognosis for these patients. Now, starting with the epidemiology, what I have done here is try to bring together what the annual CVT incidence looks like. So it's not as common as our run-of-the-mill ischemic strokes or hemorrhagic strokes. But we do have some data that's coming out, and just to give you an idea of what those figures look like, I've kind of tried to, from our region and from the rest of the world, what is this annual, incidence looking like? So this is the study from 2007, where the annualized incidence rate was reported as 1.2 per 100,000 individuals. A study from Netherlands from 2012 reported an annualized incidence of 1.32 per 100,000. From Australia, the same figure was 1.6 per 100,000, and this was a study from 2016. From 2020, it was 1.75. So you see, these are all in the range of 1 to 2 per 100,000. From the US, again, it was 1.4 to 2. Finland, 1.3. Denmark, 1.24. So again, the same range, ranging from 1.2 to 1.7. Now, most of the data that is coming out is coming from registries. And where are these registries coming from? So there are a few big registries. The biggest registry is coming out of Turkey. And this slide is going to summarize the biggest registries of note that exist in the world today for CVT. Okay. So ISCVT was the first registry that was established for cerebral venous thrombosis, and that was back in 1998. And this was the first study that was published, and from 29 countries, data was contributed, and it consisted of 624 cases. This is the international study of CVT, ISCVT, which is the most famous study on cerebral venous thrombosis. Then there was the, and this was back in 2004. Then in 2012, there was the CAVITAS study, which came from USA, Italy, and Czech Republic, which consisted of 706 cases. And this was followed in 2017 by the Turkish study, which is the biggest registry of 1,144 cases. But this is from a single country. So Turkey was in many centers, but only from Turkey. And this spanned 15 years. So 2000 to 2015 data, and this is the VNOST registry from Turkey. And I will present to you, of course, the data from these registries, but these are the main registries of note. Then there is the Danish registry, which spanned data from 1996 to 2018. There were 653 cases from this registry, and this is again also only from Denmark, so one country. And then this is the Asian registry from 9 Asian countries, 812 cases starting from 2009 to 2013, 812 cases coming out of 9 Asian countries. So these are the 5 registries with the largest number of cases that are reported. 2 of these are coming from single countries. The others are from more than 1 countries. I want to mention 2 other registries simply because they have a large number of cases that are included. They're coming out of single countries again. So there is the Indian registry, 428 cases are reported from it. And then there is one registry from China, because these are big countries with, large number of cases reported, 243 cases coming out of China. So just, because I will be presenting some of the risk factor data from these registries. So just to kind of park it there, that these are also substantial registries from which we have some good number of cases with risk factor data, at least of note to know. So it's good to know about them. Okay, now what is the age distribution? So these are basically the reason why I wanted to mention these registries is so you know that these are the registries that are our reference registries when we talk about risk factors, when we talk about the age distribution, when we talk about the basic demography of CVT. So what is the age distribution for a typical CVT case? So if you look at the ISCVT, the mean age for the patients in the ISCVT was 39 years. The Danish registry, 41 years. CAVITAS was 40 years. So that's the main age range. Asian registry, patients were much younger. So the mean age for these patients was 31 years. In the VNOST, they did not report a mean age group, but they reported that around 46.6% of their patients were in the age range of 18 to 36 years. 33% were in the age range of 37 to 50 years, and around 20% were older than 51 years. In the Indian registry, like the Asian registry, the patients were younger, so 31 years of age. And in the Chinese registry also, the patients were slightly younger, 36 years of age. So if you look at the European Caucasian population, because ISCVT mainly had a Caucasian European population, the patients were older, slightly, so 39, 40-year age range. And if you look at the more Asian population, Chinese population, the patients were slightly younger, so more like 30-year age range. Now, what about the sex distribution? So, like the professor was mentioning earlier, there is a female preponderance, and across the board, most of the registries confirm this for us. So, the cavities study also showed that 73% of the patients were females. Danish registry also showed 67% were females. ISCVT, 3/4 were females. Venous registry showed 68% were females. But in the older age group, there were more males in the 51 plus females. In the Asian registry, 59% were females. In the Indian registry, however, 46% were females, so slightly lower proportion. In the Chinese registry, it was more of a half and half sort of distribution. Now, there is a systematic analysis that I am quoting here, which showed that females are affected more commonly, and it showed that the proportion of female patients had also increased over time. 54.8% of the patients in studies published before 1981 and 69.8% in studies that were published after 2001. So with an increase, the proportion of the patients over time, female patients were growing in number. Now, when we come to determinants or risk factors, this is, of course, a very interesting area also. Again, our data is coming out of these main registries that I have just quoted for you. Looking at the main registries again. In the ISCVT, 34% of the patients, the main risk factor identified was thrombophilia, which is the hypercoagulable state, which was causing the cerebral venous thrombosis. And amongst the females, more than half of them were either on oral contraceptives or some sort of a hormone replacement therapy. And 20% had obstetric CVT. There were around 12% infection-related CVT also, and around 9% were anemic. So this is an older study, keep that in mind. So ISCVT, amongst the females, there is a large proportion that were on oral contraceptives or hormone replacement therapy. In the cavities, which is another Caucasian, more of European Caucasian study, there is a large proportion of patients who were on oral contraceptive hormone replacement therapy. Around 10% had obstetric CVT amongst the females. The Danish study also, around 60% of women had oral contraceptive hormone replacement therapy as the reason for their CVT. Thrombophilia was much less in the Danish study, but in the cavities, around 41% of the patients were identified with some sort of thrombophilia. In the venous study, the proportion of patients with oral contraceptive or hormone replacement therapy-related CVT was much less. So only 13% of the females had it. Obstetric CVT proportion was higher in the Turkish study. In the Asian population, around 18% of the women had obstetric CVT. Around 12% only had oral contraceptive or HRT-related CVT. Now, just like looking at these numbers, some sort of comparisons that can be drawn is that if you look at this Caucasian European population, the HRT or oral contraceptive related CVT amongst women seems to be much higher in the more European Western populations, whereas obstetric CVT or anemia related, for example, in this Asian population, anemia related CVT seems to be much higher. Thrombophilia related CVT, I have serious reservation about commenting on this because there are several issues with thrombophilia related CVT. One of the problems with labeling people with thrombophilia related CVT is that one, there are so many different kind of thrombophilias, and most of the studies do not specify what thrombophilia they're talking about. So they get clumped into one entity. The other problem with labeling people with thrombophilia is there is no mention at what point in time these thrombophilia is being checked. So we are going to come to the appropriate timing of evaluation for a thrombophilia. There is an entity which is called consumption coagulopathy. So it is not appropriate for you to do a testing for a thrombophilia, for certain thrombophilia in the acute setting, because it may give you a false positive result. So, most of the studies do not specify at what point in time the thrombophilia was checked, and certain thrombophilia require to be retested. So there is also no specification in most of the studies whether there was a retesting that was done or not done. So there are serious, problems with labeling people with thrombophilia in most of these registries. So we cannot really rely on whether these people truly had a thrombophilia or not. So, and then across the studies, it is difficult to compare, whether there is a consistency in labeling people with thrombophilia across the registries. Whether all the thrombophilia were tested in all of the studies or not is another issue. So whether the thrombophilia that was checked in the cavities is the same thrombophilia that was being checked in ISCVT or in venous or not. So it's very difficult, and it's not easy to compare one study with another study when you're comparing the thrombophilias. So it's those comparisons are not direct comparisons, and they should not be directly compared like that. So that's the biggest problem here. But some generic comments can be made at least about the use of oral contraceptive pill, which we can obviously make that, a much less use of oral contraception and hormone replacement therapy in the Asian population. And we know from our clinical practice also that we don't see it as much being utilized in Asian population as we see it being utilized in the West. And that may be one of the reasons why we don't see it so commonly in the CVT related to it in the Asian population. Anemia seems to be much more common in our population, and anemia-related CVT seems to be much more common in the Asian population as well. So this is for the risk factors. Now, there is some teasing out that I tried to do from these registries in terms of the thrombophilias. So some of the studies did go into some details of what thrombophilias were there. So the ISCVT reported 34% thrombophilias, and 22% of these were genetic. EPLA was reported in 5.9%, and anemia was reported in 9.2%. In the cavities, they reported 2 to 3% protein C, S, antithrombin 3 deficiency. 20% had prothrombin mutation, 9% had factor V Leiden mutation, 8.4% had antiphospholipid antibody reported. Venous reported 5.5% protein C, S, or antithrombin 3 mutation, 2.6% prothrombin mutation, factor V Leiden mutation was reported in 5.1%, EPLA was reported in less than 1%, anemia was reported in 3.2%. In the Asian registry, 36 to 40% protein C, S, and antithrombin 3 deficiency was reported. Prothrombin mutation was reported in 3%. Now, you see this kind of problem, this prothrombin mutation 3%. In ISCVT, genetic 22%. Now, this genetic could be prothrombin mutation, it could be factor V Leiden mutation, we don't know, right? It's just reported genetic. EPLA was reported 20%. Now, it's important for EPLA that it should be repeated at 12 weeks. No study reports whether there was a repeat testing that was done and it was confirmed as an EPLA. And then anemia was reported in 50% in this Asian registry. So, like I was mentioning, it's difficult to compare across the studies whether these thrombophilias, were truly existent and at what point in time they were tested. Okay. Now, there is, of course, it was more common in women. We saw that data from coming out of all registries. There is one, so all of these registries had a substantial number of women who had CVT. There were, the Venous study had the highest number of women, and a good number of obstetric CVTs were also there. There were around 10% obstetric CVTs in the cavities. There were almost in the ISCVT also 13.8% in the perpurium and 6% in the pregnancy. In the Asian CVT also, there were 26% in perpurium and 3.8% in the pregnancy. Danish study had 9.6% obstetric CVT reported. And then, of course, Venous also had its good share of pregnancy and perpurium related CVT. And then, of course, there was a proportion we already mentioned that were related to the hormone therapy that these women were getting. So of course, women were at higher risk, and these were the factors that were contributing to it. Then there was this one paper that I had the opportunity to work with. We combined data from three registries. One was from the Turkish registry, the Mexican registry, and data from Pakistan. And these were 553 cases only of obstetric CVT. There were 20% of them happened in pregnancy, and 80% were in the perpurium. And the commonest risk factors we identified were anemia and dehydration. There were around 3.8% people died. The modified Rankin was 0 to 2 in about 80% at discharge. And encephalopathy and percurial infection predicted poor outcome in these women. So it's not such a benign condition, obstetric CVT. It does cause poor outcome at discharge for these women. And anemia is something that should be, anemia and dehydration, that is something that should be watched out for and should be prevented in these women. Now, what to do if somebody develops CVT in one pregnancy? Is that a contraindication for future pregnancies? And I'll address that question here before we move on to the rest of the talk, which is on more of a generic management of CVT. So CVT is not a contraindication for future pregnancies. That's something that I want to settle here, okay? Considering the additional risks that pregnancy confers to women who have a history of CVT, it is advisable that you put these women on low molecular weight heparin during their future pregnancies, and the postpartum period is probably, it's going to be beneficial for them. The perpurial period is the highest risk period. So the postpartum is when the risk of getting a cerebral venous thrombosis is the highest. So they should be put on low molecular weight heparin during their pregnancy and also after their delivery. And the postpartum period is their highest risk period. But they should, it's not a contraindication to get pregnant again if they've had a CVT during their pregnancy. Okay. Now, we've already, obviously, you've seen through those registries what kind of risk factors may be there, but this is just a summary table of there are many risk factors that are there. There was a time when we used to see a lot of septic CVT. Now, with good antibiotics and good recognition and early treatment of infections, the infection-related CVT has gone down a lot, So we used to see a lot of otitis-related CVT. People would get ear infection and then transverse sinus CVT would happen with it. But now that at least that part of it has gone down a lot. I haven't seen a septic CVT in ages now. But that used to be one complication that used to happen. Of course, medication-related CVT with oral contraceptives, we already talked about, hormone replacement therapy and steroids. Those things put people at risk for it. Genetic thrombophilias, of course, we always, send off those testing when people come in with CVT. And then, of course, there are iatrogenic causes that may be there, instrumentation, even post-lumbar puncture CVT is reported. And then, of course, there are certain cancer therapies that can put people at risk of CVT. And then systemic diseases, of course, you have to think Behçet's is very commonly thought of, in Turkey. Behçet's is supposedly one reason for developing cerebral venous thrombosis. Neurosarcoid is also reportedly, I haven't seen any cases of neurosarcoid presenting with CVT, but these are things to keep in mind. And then, of course, post-traumatic CVT, we've seen people developing it. Dehydration, anemia. Anemia is something very commonly associated with cerebral venous thrombosis. So it's a very simple test to do, and we see it very commonly as being, people presenting with anemia-associated CVT. So easy to treat, reversible cause, and should keep that in mind. Okay. Now, how does CVT present? There are major sinuses. There is the superior sagittal sinus, there's the inferior sagittal sinus, you have your transverse sinuses, straight sinus, and the sigmoids draining into the jugular. And then you have your cortical veins. The thrombosis could happen within the major sinuses, but your cortical veins can sometimes also get thrombosed. And it becomes tricky to diagnose if it's a cortical vein thrombosis, because that might require more expertise in terms of radiological investigations, and sometimes your plain CT venogram may not be able to pick it up very well, and you might require an MR or a better CT venography imaging and a good radiologist to read those images to pick up a cortical vein thrombosis, and a clinical suspicion that is high enough to treat those conditions. So basically, most of the times it is, if your clinical suspicion is high, then of course you have to suspect it, and then you have to request the right kind of investigations to pick it up. Superior sagittal sinus is a fairly easy, thrombosis to pick up. 25 to 45% of the time, that's the one that gets thrombosed. The most serious sinus to get involved are, of course, the deep systems, deep venous systems, because the thalami, when they get involved, they can, produce some serious clinical symptoms and hemorrhages, and the prognosis can be much worse for those cases. In terms of presenting symptoms, headache is by far the commonest presenting symptom. And you have to obviously be aware of the red flags in a headache history in order to have a high index of suspicion. So if it's a sudden severe headache, which is unexplained, too severe, presenting with any kind of focality on examination, or a seizure, then that obviously warrants an investigation. We see cerebral venous thrombosis so frequently that our threshold for ordering a venogram in the emergency is quite low. I'm not sure how frequently you people see CVT, but in our hospital, there is a seasonal variation. But I would say in a year, we see around 30 to 40 CVT cases annually. That's generally the figure. And sometimes even 50. There have been years where we've seen around 50 CVT cases in a year. So, so our thresholds, particularly, in the hot months, our thresholds are low. Any severe headache, which is new in onset, we have a low threshold for ordering a venogram in the emergency. And now our eyes are tuned to picking up, even on plain CT, a hyperdense sinus or a hyperdense vein. So, we have very low thresholds for ordering venograms in emergency setups. If a patient is presenting with a headache and a seizure, then also our threshold for ordering a venogram is very low. If somebody is presenting with a papilledema as a presenting symptom, that's clearly a sign of raised intracranial pressure, and that's another reason why we would want to do a venogram to evaluate if any of this venous sinuses are occluded. People may present with focal deficits, aphasia, mental status disorders. They may be comatose. They rarely may have other movement disorders, suggesting again focality. This is a paper that was published in Nature, Nature Reviews. So, and it was derived from cohort studies that were suggesting. Now, I'm going to put in a case that I saw a couple of years ago at our center. This was a slightly atypical presentation, but I'm just putting it here because sometimes the atypical presentations should, because our thresholds are low, that's why we are able to kind of pick up these cases. Otherwise, they can completely go unnoticed. Young male, 33, he's a smoker. He doesn't have any medical conditions except that he reported that he has a history of hemorrhoids and he was recently having frequent parectal bleeding. That's all the history he was giving. He was having a new onset headache for 4 days, and for one day, there was some reduced level of consciousness. He was sleeping more than usual, okay? And his exam was showing that he was drowsy. He wasn't following all our commands. He was oriented to self, but he was not fully oriented to the place or time. His extraocular movements were full. His fundus could not be evaluated because he kept dozing off and he wasn't cooperative. His motor exam was unremarkable. His sensory exam was not reliable because he was getting drowsy. Now, this CT is done in an LT setting. Okay. So because of this headache, and like I said, we have a very low threshold for venograms. We did a CT venogram in the emergency. I'm not going to quiz you, or I'm just going to show you basically the area of interest, okay? So on the plain CT, the guy had a hyperdense vein of Galen and the straight sinus, okay? And he had a deep sinus thrombosis. So his straight sinus and his vein of Galen was thrombosed. And the reason why he was getting drowsy is because of this, right? He had deep sinus thrombosis, he was developing, and that was because he was getting anemic. His hemoglobin was 5 because of this, he was bleeding from his hemorrhoids and had become severely anemic. And because of this severe anemia, he was developing this deep venous sinus thrombosis. And he was getting drowsy because of the bithalamic edema was developing, and that's his thrombus. Okay, and this is no contrast is filling here. You see the superior sagittal is filling nicely, and the straight sinus and the vein of Galen is not filling. And this is the thrombus, because this is a non-contrast image, and the thrombus is hyperdense on a plain CT. So this was basically a case of acute CVT secondary to anemia. Okay. Now, for diagnostic purposes, there are certain indirect signs on CT. What we mean by indirect signs on plain CT is that you are looking at the brain parenchyma, not directly at the thrombus itself. And there are certain changes in the parenchyma that are making you think that there may be a thrombus that is causing these changes. So erosion of the middle ear, for example, and mastoid air cells. Okay, so that makes you, so the patient is presenting with an ear discharge, for example, and you see in the bone window changes on in the middle ear and the mastoid air cells. So that's an indirect sign that tells you that this may be a septic CVT. Okay, then you give contrast and you see enhancement of the FOX, and that is because there is venous stasis or dural collaterals, because when there is a thrombus, then there is stasis of the venous system, and that leads to congestion of the dural vessels. Okay. Then you may have linear hyperdensity along the gyri, which may be misinterpreted as a subarachnoid hemorrhage. Okay, so that's an indirect sign on a plain CT that may be seen with cerebral venous thrombosis. Then you can see sulcal effacement because of the edema, That's because of venous congestion that can take place. And then, of course, you can see hemorrhagic infarctions on a plain CT when you have cerebral venous thrombosis. And then you may have direct signs on CT, which means direct visualization. One of them you just saw. So you can see direct visualization on a plain CT of the thrombus itself. So you saw the straight sinus just now, hyperdense thrombus within a cortical vein or sinus. So I just showed you one image with that patient. This is a cord sign. So you see within a cortical vein or sinus, you can see the thrombus itself. You can see the dense delta sign on a plain CT. You can see it within the superior sagittal sinus, for example. Or you can see an empty delta sign. So when you give a contrast, the contrast does not fill up and you see the delta is empty. So inside does not fill, but around it, there is contrast filling. So that's an empty delta sign on a contrast enhanced CT due to the collaterals around the thrombus that are there, but within it, the thrombus is not letting the contrast fill. So you have the dense delta and you have the empty delta, both on CT. These are direct signs on CT. And then, of course, MRI can give you many, many clues on cerebral venous thrombosis. So one of the things on MRI that you can see is a lack of expected signal flow void on a standard spin echo that you can see. So on a T2, you can see basically the flow void that the thrombus can give. You can see in the T2 star sequence, for example, here, the presence of intravenous clot. And there's a direct visualization of the venous infarct also. So you see, this is the venous infarct. You can see it's hemorrhagic, and you see these small petechial hemorrhages that can appear along with this. The other big advantage that you can have with an MRI is sometimes if the changes are so subtle, there's a small cortical vein thrombosis, for example, and the changes are so subtle that a CT is not going to pick it up, then the MRI can just give you that subtle diffusion restriction, for example, and that is your clue. You know, those parenchymal abnormalities, a plain CT will not pick up, but an MRI can pick it. So both MRI and CT have their own advantages and disadvantages. The advantage of a CT and CT venography is that it's very quick. So it's available in the emergency. You can just, it's less expensive. You can acquire it quickly, and you can, it doesn't, there are no flow related artifacts, so it's easy acquisition. The disadvantage of a CT venography is that it's iodinated contrast, and it does not give you the same resolution that an MRI does. So the parenchyma does not show that nicely. The CT parenchymal resolution on a CT is not as good as it is on an MRI. What is the advantage of the MRI? Of course, the parenchyma shows up really nicely. If you're not doing an MRI with a contrast, the time of flight MR venography does not have the same advantage that the contrast CT venography does. So you can do a contrast MRV, which is very, very good, but a time of flight MRV only uses the flow phenomenon to acquire images. So that technique obviously is inferior to a contrast enhanced CT venography. So sometimes, like particularly when in pregnancy, for example, we sometimes use a time of flight MR venography because we don't want to give contrast to a pregnant lady, for example, right? So, so time of flight MRV is inferior to a contrast-enhanced CT venography. But if you're going to give a contrast MR for an MR venography, then that, of course, is equivalent to a CT venography. So otherwise, MR has, of course, many advantages over CT venography if you're going to give a contrast. Now, some other questions before we move on to management. Let me just check what the time is. So, okay, we don't have much time, so quickly. So what is the value of a D-dimer? So I'm not sure whether you guys routinely do a D-dimer. We try to do it mostly because our emergency is very interested in doing a D-dimer before we can do a venography. So D-dimer is a useful test. It has more of a negative predictive value than a positive predictive value. So a 2012 meta-analysis that included 14 studies that evaluated D-dimer showed that it has a 94% sensitivity and a 90% specificity. So very, very good sensitivity and specificity. The sensitivity of D-dimer for CVT lower in patients who only have isolated headache, okay? And those who have like more of a chronic presentation, then of course the sensitivity becomes lower. So if in an acute setting, when people are presenting with severe headache and, and if there is more than just a headache, then the sensitivity and specificity is higher. If the onset of symptoms is less than 7 days, then also the sensitivity and specificity is much higher. So it is a valuable test and should be used if your threshold is high. If it is normal, then the chances of picking, having a big CVT is going to be low. So it has more of a negative predictive value. The other question that people ask is, what is the right time to test for hypercoagulability? And that's a good question to ask, particularly when you are working in a resource-poor setting. Because there is an entity which is called consumption coagulopathy. So when there is acute thrombosis, there is consumption of a lot of these procoagulant factors, and that reduces factors like antithrombin, protein C, protein S. So if you're going to do those tests in the acute setting, their levels may be low. And then that does not give you a clue into whether, how long to continue these patients on anticoagulation. Also, if you have started somebody already on an anticoagulation, like heparin, for example, it can lower antithrombin levels, although it may not affect protein C and protein S levels. So if you're going to test for antithrombin level at a time when you've already given your patient heparin, then it may not be reliable. Okay, so keep those things in mind if you're going to do those tests. And you will have, and it just means that you'll have to repeat those tests anyways. So if you're going to have to repeat those tests, then it may be reasonable to wait and do those tests at least 4 to 6 weeks after an acute thrombotic event or discontinuation of anticoagulant or thrombolytic therapies, including warfarin, heparin, any other direct and factor Xa inhibitor and fibrinolytic agents. Also, one of the reasons why you might opt to do the test in the acute setting is if you're going to lose your patient, and the patient will not have any kind of follow-up later. Sometimes we do your only opportunity to do any kind of testing for the patient. So sometimes this is your window for testing, and if you can pick up some abnormality and tell the patient that you might have to repeat this test, for example, in 12 weeks' time, then it may be an opportunity to do that test and give some advice that, this might have to be repeated at a later point in time. Then it may be reasonable. Or if the patient will get an insurance cover while the patient is with you and will have to get it repeated later on without an insurance cover. So depending on what the situation is, you might have to do a make a decision, but beware that some of these tests may not be reliable in the acute setting. Okay, so quickly going over the management aspects. Anticoagulation. Low molecular weight heparin is favored in the early acute phase, one, because of the practical application, administration that it has. It has a predictable effect because heparin infusions are more difficult to manage, and it has a lower risk of thrombocytopenia. If you have to give vitamin K antagonists, then the therapeutic INR is between 2 and 3. There is an emerging role of direct oral anticoagulations. We now have 2 trials, although both of them did not reach the required numbers that we want for a good phase 3 study where we can conclude that this is enough numbers to prove level 1 evidence. There was the RESPECT CVT study on with dabigatran, which randomized 120 patients to warfarin versus dabigatran. There were no recurrent thromboembolisms in either groups. There was 1 GI bleed in the dabigatran group, 2 ICH in the warfarin groups. And then last year, there was the SECRET trial, which ended up only being a phase 2 study, only to assess the feasibility of recruitment. The 53 patients were randomized to warfarin versus rivaroxaban 20 milligram daily. There was 1 recurrent CVT, 1 symptomatic ICH, 2 non-major bleeding events in the rivaroxaban group. So we haven't had a single phase 3 study that have head-to-head compared warfarin versus a DOAC. Then we have the ACTION CVT, which was not a randomized controlled trial, but it is a multi-center international study where 1,025 patients with cerebral venous thrombosis have been compared, half on DOACs, half on warfarin. And in this comparison, which was not a randomized comparison, but patients have received various DOACs versus warfarin, and they had similar recurrent venous thrombosis risk, similar death risk, similar partial or complete recanalization. So a number of different outcomes have been compared. And the good thing was that there was a lower major hemorrhage risk with direct oral anticoagulants. So that was a good positive thing that came out of this large study, which compared DOACs with warfarin. The commonest DOAC that was used in this study, again, not a randomized study, the commonest direct oral anticoagulant that was used in this study was apixaban. More than 50% of the patients in this study used apixaban. Okay, the other study of note to mention here is a systematic review and meta-analysis where 3 randomized controlled trials and 16 observational studies were combined together, looking at DOACs versus warfarin. Total 19 studies were included in this review. And again, they showed similar risk of recurrent venous thrombosis, similar risk of major hemorrhage, and similar rates of full recanalization. So again, DOACs are safe compared to warfarin. They have similar risk of major hemorrhage and of recurrent venous thrombosis, and similar rates of full recanalization. What are the areas where we have uncertain roles of DOACs? So with pregnant and breastfeeding women, we still don't know. So low molecular weight heparins is still what is recommended for these people. For APLA syndrome, so people who have antiphospholipid antibody syndrome, there is a higher risk of venous thromboembolic events with direct oral anticoagulants. So still it is not, DOACs are still not recommended for this group of individuals. For patients with cancer, now there is emerging data that DOACs are at least non-inferior to low molecular weight heparins in the prevention of venous thromboembolisms. So again, no conclusive evidence as yet, but that this is where that uncertainty is still, kind of there. What about reperfusion therapy? So last couple of slides, there is only one multi-center randomized clinical trial that has looked at reperfusion therapy in CVT, which means thrombolysis or anticoagulation for CVT. That's the 2ACT trial. And it showed that patients who have severe CVT did not benefit clinically from endovascular therapy. Where they went in with a catheter and they tried to give a lytic to these patients who were receiving standard anticoagulation. And they found that there was not much benefit. There were larger studies and meta-analyses that showed that EVT is associated with a higher mortality and no evidence of benefit. So again, not routinely recommended for patients who have CVT. What about decompression surgery? Again, it should not be offered routinely to people with severe CVT, only in patients who have impending herniation. As a life-saving therapeutic approach, it may be offered to people. There is a systematic review and meta-analysis that included 51 studies comprising 483 patients with CVT that showed the surgery within 48 hours of admission may decrease mortality and result in improved functional outcome. So, but it cannot be routinely recommended for any patients. How long should you anticoagulate once you start patients on anticoagulation for CVT? For a variable period, depending on the underlying cause. So if you can identify the cause, it's a reversible cause, and the cause can be reversed, then 3 to 6 months. If it's an unprovoked CVT, 6 to 12 months. Those who have recurrent CVT or there is an associated prothrombotic condition that you cannot reverse, it may be permanent anticoagulation for those individuals. So that's the summary slide. We talked about the annual incidence, 1.2 to 2 per 100,000. It affects individuals mostly in 4th and 5th decade of life. Risk factors include acquired and genetic thrombophilias and obstetric causes. Either CT or MR can be used to diagnose the condition. Threshold should be low to suspect the condition. Anticoagulation is the management of choice, and reperfusion therapies and decompression is reserved for selected patients with severe CVT. Thank you. There is a SITS-MENA CVT study that has ongoing recruitment till August 2024. That is my email address. If any center is interested in contributing patients, we can share with you the criteria. We need a center that is going to be able to contribute at least 20 to 25 cases of CVT. That's our requirement. I believe my SITS coordinator shared with me the name of the name of the national coordinator. I think it's Dr. Tamim.
Yes, Dr.
Yes.
Kadhim.
So yeah, so he can get in touch with me, or you can get in touch with him, and he can get in touch with us. If any center is interested in contributing data to the study, and we can hook you up, you can become a part of the study as well.
Thank you, ma'am, for this comprehensive presentation. Now, we would like to move to Dr. Hayder if he has any comments. Sir,
Thank you very much. Thank you very much, Dr. Marwa, for this interesting talk and comprehensive, in fact, review about the topic. I know there's many issues need to be discussed more and more, but I think this is quite beautiful and enough as an educational program for our colleagues and junior staff. In fact, in daily practice, just I have one comment. In daily practice, we come frequently to see patients with polycythemia and venous thrombosis. it's quite common, one of the common causes that can be corrected easily, whether it is idiopathic or it's secondary to the smoking, or even the use of shisha recently is widely spread among our young people, especially male patients. I have questions regarding the prophylaxis use in pregnancy. In fact, this is, I think, needs to be discussed more and more, because to keep the patients, especially pregnant women, during the gestation for a long time on low molecular weight heparin, which is less teratogenic, of course, as you know, is highly expensive for our people. And you mentioned very beautiful words. You said improbable used in the, I know ISO guideline as well as American high guideline. They put this as an issue in the guideline, but they not estimate the exact dose of low molecular heparin and for how long. Is it from first trimester or the third trimester? My daily practice, I don't give it routinely. Yes, it is not like the guideline. I not give it routinely for all patients having CVT before, to have a prophylactic use of heparin during the gestation, whole the gestation. I looked at the patients with a special setup. For example, if he had additional risk factor, maybe it's logical to keep the patient. So I would like to know your opinion about this issue, which is very important to us, in fact, because this is really in touch with our daily practice. The other question I would like to stress here, that improvement of the patients after 3 to 6 months of therapy in a provoked CVT, or you may extend it to 12 months in the unprovoked CVT, is not enough to say that recanalization is happened, because it is very well known in the physics that when the patient's improving and the flow, because the main problem in the venous occlusion is the pressure. When the pressure is decreased, the patient is improving. There is less parenchymal damage in the pathophysiology, So we have to follow the patients carefully for the patency and potency of the vein, because you maintain the patency, yes, but the potency of the vein is not guaranteed. And this is why, with my daily experience for a long time, the patients may be presented with IIH later on because of the venous insufficiency secondary to the CVT. So my question is that, first of all, as I mentioned, that the prophylactic use of heparin in pregnancy, this is number one. And number two, the recanalization is not always happen in spite of the improvement in the symptoms, and the patient's doing well. Thankful for the management, and that's all. Thank you very much, Marwa, for all the things and for your nice talk.
Okay, thank you. I think I have much to learn from your experience. Obstetric CVT, I don't see. In UAE in particular, in my practice, I haven't seen much. I've worked with a lot of data that's coming from other centers, but in my daily practice, I haven't seen any. You mentioned polycythemia. Again, in my practice, I haven't seen any. I've seen a lot of anemia-related CVT, but I haven't seen any polycythemia-related CVT. So, in terms of the use of heparin, I see that there is a lot of practice here of use of low molecular weight heparin. I think the obstetricians here have a very low threshold of using low molecular weight heparin for various other reasons during pregnancy. So that I've seen the use of this for VTE prophylaxis very commonly being used. Not particularly for CVT, but for other reasons. There's a very common use of low molecular weight heparin in obstetric practice here in UAE, at least. That's one observation I have. Now, in terms of CVT prophylaxis, I'm not sure. I mean, your question is whether it should be routinely used if somebody's had a CVT. Is that your question?
Yes. Yeah, if the patients have history of CVT, that's during a pregnancy, there's, according to the ESO guideline,
Yes,
if
they
you
recommend that
for
you should.
prophylactic heparin for 8 or 7 months, but there is a conflict about the dose of the low molecular. They agree about the use, but the dose is not very well validated.
Unfortunately, that kind of data, Professor, will not come from them because it's not their problem. It is our problem. You know, we see it much more commonly. So those kind of studies, I think, should come from our part of the world. You know, we are, I mean, if you are seeing obstetric CVT, and I think the Asian registries had a lot more obstetric CVT, perhaps more of our multi-center collaborations could come up with some observational data, at least of this sort, where we can show that, you know, patients were put on these kind of doses and they did well. You know, we can at least start to report these outcomes where people have done well on lower doses and did well, you know, and at least start to address the reversible things, you know, like dehydration and anemia, which we've already reported are important risk factors for poor outcomes in these patients. So so at least, because I doubt whether we can expect to see these kind of studies coming out of the Western population. It's not such a common occurrence in their part of the world. So I don't think that they will have much studies centered around this.
So what do you think if you have patients with CVT before and now pregnant? Do you keep your patients on the prophylactic
Yes.
heparin or not?
Yes, we would.
For how long and at which time you start during the gestation?
Probably third trimester.
Yes, I'm totally agree. I think it's good practice because to keep the patients for 9 months is too
9
long.
months is too much, yeah.
Yeah.
9 months is too much. Third trimester, because that's generally what the data is also
And
suggesting.
you give low dose or how much the dose you are going to use?
Probably, yeah, low dose. Low dose, yeah, I agree.
Thank you very much.
And sorry, your other question was about?
Recanalization of the vein.
Yeah, that's another very interesting area. You know, so there is a lot of data now about this intracranial hypertension business happening in the wake of CVT. And now with this intervention business happening and stents and all of this for venous you know, intracranial hypertension, there is obviously growing interest in that area. I think recanalization is not properly studied in terms of the effect. If you look at this Action CVT registry and the systematic review also that I shared some of that data, the recanalization data also is not, it's not very well understood. You know, people have not really looked at whether the recanalization is properly studied at 3 months, at 6 months, and is that really an outcome that we should be looking at? Because sometimes symptoms resolve and people have chronic occlusions that will always be there. But does that mean, should we be aiming to get it completely open or not? You know, sometimes you just anticoagulate the patient for 6 months, and you don't even repeat, there's no standard recommendation to repeat an angiogram at 6 months before stopping. There's no standard recommendation like that. So sometimes we even, I've stopped anticoagulation on patients who are not affording and don't want to repeat an angiogram, but their symptoms have completely resolved. They don't have a provoking factor, and you just risk it, without doing an angiogram. So there are cases like that as well. And sometimes these are just chronic occlusions. You don't want, you will never see a complete recanalization. They're just there, and they may not cause any symptoms. And sometimes you can have those chronic headaches happening. And so there is a proportion of patients who will end up with those symptoms as well. And those are the outcomes that should then be monitored and treated differently.
We have interesting idea to do the Doppler flow follow-up for those patients now in our center, at least, because we did many studies published. You can go ahead in the PubMed and you see it, that a Doppler blood flow can assess the venous circulation sometimes. We did that in the vascular insufficiency that have been mentioned by Zamboni in Italy regarding the multiple sclerosis and venous insufficiency. We proved that with the AUB in Lebanon by Dr. Yamud, and our study also locally in Iraq to prove that venous insufficiency can be followed by the Doppler. This is very interesting because, this is less invasive, easy techniques, just to ensure that the flow is good in the occluded veins. I am talking about the major veins, not the cortical
Major
vein.
sinuses, yeah.
So this is, I think, is very good idea to follow. I do it by myself before, but because of lack of time, we have many junior staff, they do it now, and many radiologists interested to do the blood flow assessment by a transcranial Doppler. I think this is another point we have to discuss more, and we make collaborations with other centers to see what's going on after the patient's improving. We do Doppler before and we do Doppler after, and then they follow the patients, for example, after 2 to 3 months to see the potency of the vein which have been occluded. Now I ask Dr. Sara if there's any questions for Dr. Marwa. Please, Dr. Sara, please, Dr. Mustafa. You can summarize the question for our distinguished speaker.
Thank you, sir. Thank you, Dr. Maria. It's your role, Dr. Sara. Go on, please.
Thank you. Thank you, Dr. Maria, for your nice presentation and comprehensive scientific informations about cerebral venous thrombosis. I think you already answered many of our questions, but I will start read the question in the chat. First question from Dr. Mustafa. Could cerebral venous thrombosis be asymptomatic? You hear me, Dr. Maria?
Well, if it's asymptomatic, we will never know.
Okay, thank you. Second question from Dr. Mustafa.
Okay, there's one way that I can answer this. So sometimes people present with intracranial hypertension, okay? So when people are presenting with headaches, one of the things that, and signs of intracranial hypertension, then one of the investigations that we would like to do is a venogram. That's one place to start to make sure that they don't have a chronic, venous thrombosis that is accounting for this sort of presentation.
Can I have a comment about that, please, Maria?
Yes, please.
We did a study, I think, again, it's published in Neurology Asia, about the silent DVT among stroke patients, silent DVT. So the silent venous thrombosis is common in 6% to 9% of stroke patients. They have silent DVT detected only by venography or by Doppler ultrasound. And this is why all of a sudden the patients die. We don't know why. And this is why we try to clarify this point. When I came early in the morning sessions tour and I asked my junior, what happened for these patients? he said all of a sudden severe chest pain and frothy secretions and hemoptysis, and then died. But he had no signs of DVT at all. So we try to study this and we stress these points, but silent DVT can happen in stroke. The silent venous thrombosis in the intracranial veins, logically and theoretically speaking, can happen, but as you mentioned, it's past unnoticed how we can detect. So many patients presented with headache because of probably small venous thrombosis, and this dissolve and happen, just like a TIA, for example. I am talking about theoretical aspects. So I think this asymptomatic CVT can happen, but we have no data about that. But logically and theoretically speaking, can be happen. But practically speaking, it's very difficult to say, because we have to have a study for that. We have evidence-based medicine for that. We can't screen for all patients, for example, with headache, without any signs of increased intracranial hypertension, without any heralding signs of venous thrombosis, and we can do venography. But this is difficult, because this is not a routine test to be done. It is a risk of radiation, the cost, and this is just my comment, Dr. Almania. Thank you.
Okay. Thank you, Dr. Hayder. Thank you, Dr. Maria. I want to add, for any person who want to share his voice, please raise hand. Now I read the second question from Dr. Mustafa. For a duration, is recanalization taken in consideration? I think you answered this question already, Dr. Maria.
Yeah, well, the guidelines don't seem to suggest anything about recanalization or a requirement or to image the veins again to decide about the duration, but to be honest, a lot of times we do venography for our own comfort levels. And if we don't see recanalization, sometimes we tend to extend the duration of anticoagulation, just to make sure that recanalization is achieved. So there is no standard guideline to recommend that practice.
Okay, thank you. From Dr. Sawad, Dr. Maria, do you have idea about neuroimaging criteria for venous infarction? Neuroimaging criteria.
Neuroimaging criteria? Well, venous, I'm not sure what that question means, but venous infarctions they don't look like arterial infarctions. They don't follow territories. They are often hemorrhagic. They don't have clear boundaries. And is that what you mean? I'm not sure if I get your question correctly.
Okay, thank you. Also from Dr. Sawad, is there a rule for acetazolamide in treating intracranial hypertension in cerebral venous thrombosis?
That's a very controversial question. Some people like to use acetazolamide to treat intracranial hypertension in CVT. It is not evidence-based. Some people like to do it. There's no good evidence for it.
Okay, thank you. I want to ask you, Dr. Maria, if you what you prefer, what's the type of oral direct oral anticoagulant for the venous thrombosis? If you prefer anyone from about the other, about rivaroxaban, bexaban, or the bigatron, from your experience?
I use rivaroxaban most of the time for two reasons. One of the reasons is it's once daily dosage. The other reason is it's slightly cheaper than the others here in UAE, although it is also more expensive than warfarin, clearly. But
okay, thank you.
no, I never use LP to relieve elevated ICP.
Dr. Maria, please, about the septic thrombosis, what's you are planning to start, whether or you wait at least to control the infection and you start, as this is usual teaching we taught for many years.
Yeah.
But whenever we have infection, we have to avoid the
Yeah. So if
anticoagulant.
it's cavernous, I'm very careful. If it's cavernous sinus, then I'm very careful.
If it is otitis, for example, otitis media.
I'm a little braver when it's otitis, but maybe a lower dose of Clexane and a little later on the oral, use low molecular weight up front for a little longer before switching to oral. But I'm a little braver but with cavernous, I'm more reluctant to.
In our daily practice, we use high molecular weight heparin.
Yeah.
You know why? Because it is easily reversed when something has happened. And this is very interesting point that have been mentioned even in ESO guideline as well as American stoke guidelines regarding the use of high molecular weight heparin versus low molecular heparin. If there is any superiority of the both of between these two, I know there's many studies done, and they have a slight difference between the high molecular weight and low molecular weight. I mean, fractionated and unfractionated heparin.
I'm not sure.
Comment
The
about
only
that?
reason why I don't like IV heparin is, it just becomes a total muck, when they can't get the APTT right, and it's just, it's yo-yoing up and down. Sometimes it's just through the roof, and then at other times it's, it's just very poorly managed somehow, and you get the feeling that half the time the patient is not in the right therapeutic range. So it's better to just give one injection and get the peace of mind that,
Yeah.
So I don't prefer IV heparin anymore.
Yes.
For that reason.
Thank you very much.
Thank you, Dr. Maria. I want to ask you also one question. You mentioned the one of the causes of the venous thrombosis, dural arteriovenous fistula. You mentioned that. Yes. You noticed this in your cases, or only you mentioned in the risk factor for the venous thrombosis?
I have never seen a case of this. It has to do with the flow dynamics, basically. It arises because of the flow differentials.
Okay, thank you. Thank you. Thank you for your time. Thank you for your presentation on your time.
Thank you. Thank you, Dr. Sara. So there is no more questions?
No,
so no more. No more questions. So
no more questions. Thank you.
Okay, I'd like to thank you all the audience and our esteemed guests and the panelists and Dr. Sara. And I'd like to remember our members and our attendees about the upcoming events. We have in the next month, the Iraq Stroke Thrombolysis Summit. We invited all the neurologist members of the Iraq Stroke Network to share their experience in thrombolizing patients and waiting their responses via the email. And I'd like to invite all the attendees, including Dr. Maria, about the first Iraq Stroke Conference. The team is planning to establish this conference during September this year. And I'd like also to invite all the attendees to follow us on the social media and the Instagram, Facebook, and also YouTube, the YouTube channel. We will upload the lecture via this website. And also, finally, I'd like to invite all attendees to join the network via this Google Forms link, and we are waiting for their valuable contributions. Last but not least, I'd like to thank the sponsor and the partner, actually, of the Iraq Stroke Network, Al-Ma'mura Scientific Bureau, namely Dr. Alim, Dr. Amir, and Dr. Humam. Thank you for your efforts. And thank you for all attendees. Thank you, everyone.
Thank you.
Thank you, everyone.
شكرا مصطفى.
Thank you, madam.
شكرا.
مع السلامة. شكرا جزيلا.